All right, official good morning and good welcome or good day to you. So we are on day 2 of the Masterclass series, and today I wanted to walk you guys through my arm and shoulder protocol. Arm and shoulders are the arm and the shoulder control the most important tool on this planet, which is the human hand and the human thumb. The human thumb, by the way, helps shape our cortical brain. Our cortical brain, our thinking mind, evolved out of our somatosensory and motor cortices. And it did that when we were able to use our thumbs to shape tools and walk upright and view the horizon. So that's pretty fascinating stuff. The human thumb shaped our world. It made us the people we are today. And today we're going to go over the entire complex that facilitates that movement there. So we're just let's start with a quote from Stephen Porges. So we must look at the bodies as state change entities and as the therapeutic relationship as an optimistic emergent process to retune the nervous system and return the body to a safe zone. Pretty powerful words there. So state change, we're always changing. We're always finding this baseline homeostasis. This homeostasis changes, so we are just always kind of in between, just based on our protective responses. Are we ramped up because we think that that's what we need to be in, or are we able to calm and find a more stable baseline? And the therapeutic relationship is huge. It's a major part of that. We are co-regulating with another as an optimistic emergent process. I love that phrase right there, because it's optimistic, it's emergent. We have to go through it with the presence of another, and it's a process. It's not going to happen once. To retune the nervous system and return the body to a safe zone. All right, concepts review. So this is the 6 concepts that I walked you guys through yesterday. So concept 1, we want to find and elicit the somatic reflex, and most in particular, down the limbs and limb dynamics. We want to elicit a long latency reflex. Long latency reflexes are basically what govern our predictive motor patterns. And if we start to lose contact and control with those long latency reflexes, they're happening below our level of consciousness, but so is our ability to utilize them. So if we start to lose that ability to utilize them, we start to lose functionality, start to lose posture, and that can influence heavily on our mood, disposition, and behavior. Using breath as a coping strategy and an autonomic regulator. I'm going to go over this one more time here in a couple slides. Open pack positioning for ease of soft tissue manipulation. Also closed pack, I forgot to add there, closed pack positioning for ease of compression or decompression, which is traction, and we'll go over that. Finding 0 points in the joints, girdles, and the spine. So 0 points being 0 mechanical influence from any of the tendons or the muscles, or the muscle tendons. So again, in traction and compression, we'll see that we need to utilize these 0 points. We need to find these points in the body. And pin and maneuver situations, those I'm just gonna have to demo as we go along. You're going to see those at the hinge joints primarily, so the elbows, the knees, and a little bit you'll see us do in the ankles. Typically, I said we don't use a sharp instrument like our thumbs, but in pin and maneuver situations, you're going to see that it's appropriate to start to introduce some sharper tools, because the tendons get so finite, they get so little, that we need to use our thumbs to guide the reflex to happen. And that typically that's a really good spot to use oil or a medium. So in pin and maneuver situations, we'll use those. And then the relaxation response, key ingredient to all this. So so if you're going to take somebody through a reflex, you have to guide them. You have to guide them through the reactivity, which isn't going to be too much. We really only want to use a few grams of pressure, but you want to see them come back and relax into it. And you'll see that the muscles start to, they may contract at first, but then they'll let go. Just a simple breakdown of my routine, guys. Prone, 60 minutes, supine, 20 minutes. I didn't put 20 minutes right here, but so prone, why do we start prone? Not everybody can start prone, especially clients with, you know, I don't want to say safety issues. I want to say clients that need to feel safer. You're not always going to start prone, but you know, a majority of people can start prone, and I think it's really important to start prone because it is this turning off of the cerebellum structure. It's this absolute turning. You're putting somebody in a position like dynamics that they're not used to, so they have to situate themselves horizontally in their brains while they're laying face down on the table, and it's so therapeutic and so important. And so we start there. We always want the head in a neutral position. I don't know if you guys are using tables without a head cradle or a headrest, but I do not recommend it. Where someone's face is in the table, that's not ideal. Get something where you can elongate the neck and keep the head in a neutral position. So we warm up the back, we internally rotate the arms, we traction the sacrum and traction the legs. This is just the basic, how do we get the communication to start? Then we move to the backside, we go superficial to deep. Shoulder and arm ×2. Hip, leg, ankle, and big toe, super important, ×2. Supine, we flip them supine, and then we go abdomen and legs. You'll see abdomen and legs are kind of tied together. Arms, double the arms, and then we do the head and neck protocol. I'm showing you this, guys, because we're going to start our first 2 demo classes are going to be arms and legs, but I need you to see this to know that we got to start with the back first. Almost everything is tied into the thoracolumbar fascia, and we really want to affect that before we move into the arms and legs. Although the arms and legs are going to be probably one of the most, and the head and neck, probably one of the most important areas that we focus on. Just the peripheral nervous system has such a long way to travel, and if we can affect these peripheral nerves all the way down there, you know, we can change limb dynamics, and we can change somebody's like spatial recognition of their body. It's so cool. So they get up off the table going, whoa, I can walk again. But so this is my routine, just a very, very quick reference of it. All right, yesterday, some key points landed. Proprioception, proprius, literally meaning of oneself, is the sense of one's joint, muscle, and tendon placement in space via reflexes and reflexory information. Proprioception is the like sandwich of exteroception and interoception. Exteroception being pain, hot, cold, pressure, and then interoception being the less evaluated internal landscape of our body. So our viscera and heart rate function, stuff that it's almost like we lose the ability to keep track of it more and more as it gets to the midline. You can see that like pain is really like a sharp presence. And then the knowledge of your body in space is a lesser known presence, and then the internal sphere of your body is a hardly known presence. And we, you know, we really want to focus, we really want to bring presence back to those areas that have a little bit more difficult of a time. And yeah, that's the key to treatment. That's really it. We don't really have a language that facilitates internal landscapes. You know, the French do, well, Latin languages do. I know that Arabic languages do, but you know, English language is very limited. We don't have this, like, interoception is literally all we have to talk about our internal feelings. Everything else is kind of tactile. You know, we only have, we say, you know, things are rough, things are something, you know, anything that has to do with like a feeling. That's our language. So Kelly's Brazilian, and they have this word saudades, which means like I long for you with every internal part of my body, or I long for your presence. And it's a beautiful word. We don't have like that. Proprioceptive knowledge comes from, and proprioception, exteroception, interoception all land in the insular cortex. They give us our sense of self. And the somatosensory cortex. So proprioceptive knowledge comes from sensory mechanoreceptors, which determine pressure, rate of stretch, and muscle tension. So we influence these with our hands, these mechanoreceptors. And they communicate via something called the somatic reflex arc. Sensory nerve info determines the tone amplified to motor neurons, which contract muscle to give us posture. All of our muscles are under tone all the time. It just depends on if that tone is in a healthy range or if it's given us dysfunction. Yeah, okay. So this tone can be disrupted in a process called gamma feedback, and our muscles become disproportionately contracted. Gamma feedback is not a bad thing. Gamma feedback is what keeps our muscles at a healthy operating length. And like, so if the muscle is stretched, gamma neurons kick on and they tell us, hey, that's a healthy length. But if those gamma neurons are not getting appropriate facilitation, they're like, okay, well, just to get this human right, we're going to allow that muscle to get to here. Or they're like, we're not strong enough to get the muscle to here. It's one or the other. So they send our muscles into hypertonicity. Hypotonicity, by the way, is only really a nerve. Muscles are really only hypertonic. I think hypotonic has to do with like flaccid muscles, and really then you have to look at brain lesions and spinal lesions as the core culprit in hypotonicity. But hypertonicity is certainly a gamma feedback product. So our goal is to challenge the mechanoreceptors of the muscle, most specifically the Golgi tendon organs, the nerves at the tendons. And the trick is that we are doing it in the most calm, stable, and safe environment as possible. We don't want to go digging in and alarm the system and make it back up. We want to slowly coach out that relaxation response so that so that muscle stretch is received in a like almost near cortical way. So like we're shaping the structure of the body in the brain rather than making it a reactive state. And we do that by reading and witnessing the long latency reflex. So the long latency, this is the short latency reflex, protect, I gotta protect. It's governed by the spine. It doesn't even really reach the brain. The long latency reflex takes a little bit longer to kick in, and that tells us that it's hitting different structures of the body that are cortical or like nearly cortical, so brainstem and somatosensory cortex. And so the long latency reflex is what we hope to evoke with our hands. These are reflexes that take a second sometimes to facilitate. Here we have the simple reflex art, guys, and this isn't representative of a long latency reflex, because the long latency reflex, it goes from spinal cord to cortical process. So the cerebellum and the medulla, and so here's a simple one. If someone is someone's reacting, it's only going to reach the spinal cord and come back down to the muscle belly. But if we hold on to our stretch for a long time, then that long latency reflex kicks in, and we're able to see it hit the brainstem. So yesterday, some concepts needed help. So my 0 point concept is the figurative path of least resistance. So where the tendons of the joint can realize that their baseline resting tone is off. When we create the stimulus safety, they auto-correct, because certain muscles are allowed to relax and certain ones are allowed to engage again. We're influencing the tendinous insertions of many muscles at the same time by finding these points. So where the stretch it's where the stretch mechanoreceptors lie. So, and the body wants to increase tone to weaker, more elongated muscle. This increases their strength that comes from the chronic posture pattern. So what that means is the body has this innate want to send the appropriate gamma feedback to the muscle structure. It's just not getting the facilitation it needs due to behavior, due to stress, due to a number of factors. So illness. So it's the body naturally wants to do that, but we're just helping to facilitate it as providers, as hands-on providers. Quick review: open pack position, position with the least amount of surface congruency, so 90 degrees at the elbow rather than 180. So the capsule and support ligaments are lax. Accessory motion or joint play is maximized, so we can move a lot. The closed pack position with the most amount of joint congruency. So I don't know if it's at least or most with the open pack, but open pack is the least, closed pack is the most. And capsule and supporting ligaments are maximally tight, and accessory motion is minimized. Soft tissue work is supposed to be done in the open pack position. Very rarely will you see me do soft tissue work in the closed pack position, but except for one spot, and that's the medial knee. And I will show you guys that when we get to the leg. All right, breath as a rhythmic coping mechanism. So I have individuals breathe into the passive movements and mobilizations. You'll hear me coach the breath about 50 times a session, more if the client is newer or having difficulty following along to the rhythm of my hands. Two things happen when the body starts to find a breathing style that is rhythmic, which is pre-Botzinger neurons, and deep, which are these psi neurons that we have in these like inherent psi neurons that are in our medulla, and the diaphragm also gets a workout. So the psi neurons, you see your dog do this like on a regular basis. So it just takes a double inhale and then an exhale. We're coaching that pattern back out on a table. So it's extremely important for neural health. And it's something we kind of override during the day. Like I don't see us going, and it's just this like inherent process that we have. Sometimes we do it, but you'll see on the table, it's really easy to get somebody to take deep sighs. And the diaphragm gets a workout, like I said. This helps facilitate autonomic parasympathetic arousal while also disarming protective responses. Okay, some definitions needed defining. A fulcrum is any positioning of my hands and fingers, typically wedged with a table, so that I can leverage up on a joint or tissue structure. You'll just hear me say, I'm going to use my hand as a fulcrum here. Fulcrum is like a lever. Traction and compression. A manual traction involves the practitioner using their hands on the patient's body and providing tractive force on the patient's body weight. So we want to use these at the ball and socket joints, and also a little bit on the spine, and I'll show you when we get there. Very, very important for finding the 0 point. So that zero balance point where there's no mechanical influence on the joint. Hypertonicity, so muscles acting out of their regular healthy nerve tone. Hyper, overly, tonic, toned. All right, guys, so I want you to, we'll do like a functional exercise here, and we'll do it from our seats. So let's start with shoulder shrugs, just very simple. I want you to slowly move the shoulders up to the ears, if you can, but hold them there. You may start to shake because they're usually not even. And really, really, really shrug. So up, 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 up. And then start to take a few deep breaths. Good, and then drop. And then you'll do that again and again. So you notice like a pretty big change when we take a few deep breaths in that shrug position. That's a really good opener of, it's called a bilateral contraction. So one side's going to be weaker and one side's going to be stronger. But the weak side gets to recognize that the strong side's too strong. And with the breath, it slowly starts to integrate. I need to change my gamma motor structure, and I need to increase nerve tone in these muscles that are weaker. But we need to hold it up there rather than like up and down, up and down, up and down. If we hold it up there and we start to breathe in, we notice the change. Pandiculations that's a real cool word. Pandiculations is a natural phenomenon. You see cats and dogs do this. Cats and dogs, by the way, are great research partners. So pandiculations are, they're just these massive stretches that we undergo, like whole body somatic stretches. So you can imitate this, we do this when we wake up, is and you can do this all the way down to your feet, right? So using the entire body to get these full pandiculation stretches, really amazing. When I say somatic tool, I mean like all your spinal nerves are going off at the same time. So that's a good exercise. Nerve glides, which you'll see us do on the table. So imagine that there's a point in between your palms, and I want you to, not 90 degrees, but 80 degrees, slowly push your arm out, both of them, and hold them there with the wrist broken like this. So it's almost like you're shooting fireballs out of your hands, right? And then take deep breaths. All right, there you're experiencing nerve glide. So the nerves are gliding over, in particular the ulnar nerves gliding over and the medial nerve is gliding over the elbow. It's also in the hand, you're gonna feel it, and then also in the brachial plexus up here. And reticular stabilization, it's just a shoulder property. So if you just hold like a teacup, like if you're just holding it in your hand like this, or some sort of weight, then your joint at the shoulder has to reticularly stabilize, like engage a whole bunch of muscles at once, and just to keep that thing in your hand stable. So if you're a waiter, waitress, your shoulder's doing a lot of reticular stabilization, as well as the elbow. are you able to recognize when I'm looking at questions, are you able to recognize when a tone is weaker? Not until you do it consciously. And these exercises are great for conscious awareness of a weaker side or a weaker tone. I highly recommend doing bilateral exercises so before moving into single leg or single arm exercises, you want to maybe do one round of bilateral, both sides at the same time, so you get to see, and each side gets to recognize which one has a weaker influence. Okay, where am I at? Ooh. Okay, the complexity of the myofascial and nerve structures along the arm is mind-boggling. The arms have controlled finest instrument of the world, the human hand. For us, the shoulder is supported by a structural column, a yoke that half hangs off the neck and half rests on the top of the limbs. So when we include the weight of the muscles, the shoulder girdle is remarkably heavy and can easily load the neck and spine significantly and detrimentally if it's out of balance. While the arm and leg are similar in construction, and you can see here the construction of the arms and legs, the shoulder and arm definitely evolved toward mobility, while the leg and hip are designed more for stability. And this is very apparent. So you ever try to run without your arms? The long latency reflexes keep our arms paired with the opposite leg for coordination, balance, and skill. So this should be symmetrical, and it never is. And it's really important because it's awareness of our body in space. And we really help to influence this when we work down the limbs, and most particularly the arms and shoulders, and we'll show you that. There are numerous nerve compression syndromes that cause significant pain or dysfunction in the upper extremity. Neurological sensations, foundational and critical component of every client's experience. We hear a lot about muscles and fascia. We hear a lot about muscles and fascia. I think it's more helpful to think of a massive neuromyofascial person. All muscles working in cohesion at once, all fascia creating the lattice structure of the body and giving us support, and then nerves feeding the muscles at the very distal ends and keeping them in a tone. You know, we dissected the body down, but now it's time to look at things a lot more globally. And so I say that, and I'm going to dissect the body down. Okay, it's called a girdle for a reason. It's held up by muscle tissue. So in humans, the only true anatomical joints between the shoulder girdle and axial skeleton are the SC joints on each side. That's the sternoclavicular. So there's no anatomical joint between the scapula and the rib cage. Instead, the muscular connection, take the word physiological joint out there, but the muscular connection permits great mobility of the shoulder girdle compared to the pelvic girdle. Because the upper limb is not usually involved in weight bearing, its stability has been sacrificed in exchange for mobility. And this is apparent in the roundhouse. So the shoulder musculature is a landing zone of tensile strength and structural integrity. The postural position of the shoulder rests largely within the scapula. So the scapula itself is a roundhouse of muscular poles, all competing to dictate its position. So the scapula floats in a sea of muscle and fascia and nerves. And those muscles can be tense or relaxed, competing and restricting, or they can be ready to accommodate mobility. Okay, scapular X, 4 muscles compete to set the primary scapular position. Rhomboids, serratus, anterior form one leg, while the lower trap and pectoralis minor have an antagonistic relationship along the other leg of the X. So what's this mean? This means that these muscles do the primary pulling and and stabilizing of the shoulder blade, the scapula bone right here. So you can see how it's just being fixated between that X of tissue. It's a pretty bad picture, but it shows us that everything is tying us together, and it also allows that scapular X allows elevation, depression, retraction, protraction, lateral rotation, and medial rotation to happen at the shoulder girdle, so mobility. You can see how everything is tied together. So here you have the rhomboids and the spleni muscles. They're creating it's just a girdle of, it's a girdle of it's literally a girdle. It's holding the shoulder up. And then you have the serratus down here, creating that same common girdle. So you can see how the shoulder dysfunction can tie into head and neck issues. We have the subscapularis and the rotator cuff. Rotator cuff is fixating the arm bone to the shoulder girdle. It's 4 muscles, so subscap, supraspinatus, infra, and teres. Really important that we have this because when it gets taken away, which it so often does, a lot of us are going to have rotator cuff stuff, unfortunately, in our lifetime. The trap takes over. The trap just like locks you in, and then you see people with these restrictions, and so that's an inherent protective mechanism that we have. And so rotator cuffs, when we talk about nerves and nerve stuff, this is having a rotator cuff is the mechanical side of things. It's actually the nerves will take over the muscles to protect a mechanical problem. And so it's unfortunately, it's a thing that is usually recommended to I don't recommend surgery, but that's one that we look at for surgery. Okay, you have serratus anterior, long, lots of muscles connecting to the ribs and the inferior wing of the scapula, or the medial wing of the scapula. And so that fixates the scapula down onto the body. Super important. We're gonna work with this. And then you got this big thing here. The lat's not traditionally part of the shoulder, but you can see that it's hanging into the arm right there. So we're tied together. This is a primary pushing muscle. So like a muscle involved in pushing. And when we mobilize the arm, this gets affected. And it's really just important to see here. Okay, movements of the shoulder, lots of them. So you got elevation, depression, retraction, protraction, upward rotation, and downward rotation. And all these muscles are the ones that facilitate that. Okay, the shoulder and breathing. Typically, you'll see one of 3 patterns. The shoulder girdle moves straight up with the breath and back down on the exhale. In this case, look to the muscles that hold the shoulder to the ribs, serratus and pectoralis minor principally. 2, the shoulder girdle hardly moves, even with a deeper breath. In this case, the shoulder is hanging off the neck and head, and you should look to the trapezius and levator scapula that hold the shoulder girdle from above. And 3, the shoulder girdle moves up and down on the inhale, down and in on the exhale. This is the Goldilocks movement, so just right. This shoulder is loose enough to ride and glide on the rib cage in response to the breath. And what happens when these muscles are outside of their baseline resting tone? You get this cross, you get this upper cross that's very common. You get there's that word hypertonic. You get the hypertonic muscles, which are just, they're tight and short. Even though they won't feel tight, they will be tight. Now the weak and inhibited muscles will be the ones that feel tight. They're the ones that are compressing down on on nerves. They're the ones that are that the actual nerve structures are at their weakest. They can't hold a proper tone. And so you just have this firing off all the time. And then I want to show you guys this because lines of pull, fascial lines of pull are important. On the right is the thoracolumbar fascia. It is a lot of connection points. Look at all the muscles that are feeding into it and all the ways that, you know, our shoulder and our back and even our hips and legs are going to be tied to our spine and really integrating our posture upwards. And then down the arm, the compressive forces of fascia make sure that, you know, when we pronate and supinate and raise our arm, that everything is working in like a cohesive way. And it's really, that's a beautiful process, but it can be impeded. Okay, guys, really important that we cover nerves because nerves, these are very long nerves and they are the ones that are sending the sensory information up afferent, and they're also the ones that send the information down to create the posture efferent. So you got the long, the axillary, the musculocutaneous, the radial, the median, and the ulnar. And remember when I said that flexor muscles are the most, that they're the oldest muscles in the body. They're the ones that we attune to. They're the ones that protect us. And the extensors are the ones that evolved out of our upright walking and our posture. Well, our nerves reflect that. We got 2 nerves down the arm for flexion, and we only have 1 for extension. So the median and ulnar nerves, primary flexors of the arm, hand, and wrist. So when we have to draw away, that's where we got double the strength to do that. Also innervators of the hand, right? So fine motor function. And you got 2 nerves moving into the thumb. Okay, your dorsal scapular nerve is primary innervator of trapezius and rhomboid major, major fixators of the shoulder blade. And you got the long thoracic nerve, which is the serratus anterior, also a fixator of the shoulder blade. You can see they're coming out of the C5, C6, and C7 here. So I forgot to mention that these come out of a brachial plexus, C5, C6, C7, and they head under the clavicle. And you'll see that in thoracic outlet syndrome, that's a major pain point. But you can see how you can see how nerve function down the arm affects head and neck. And then just to cover these are cutaneous nerves. So these are also going to be receiving stretch, pain, and pressure signals from the skin. Okay, convergence. You guys are going to see this in action when we take the arm out. When we move across our joints, tension forces that are applied to nerves will cross them. Nerves will actually slide toward the point of applied tension. And this concept is called convergence. Essentially, neural tissue is lent from either end of the nerve. It allows for tension to be distributed more evenly along the nerve rather than to build up too much on one point. So nerve tissue, like I said, is very fine, very finite, very delicate. And we have these inherent protective responses. Our body will just help out so that those nerves don't get damaged. All right. dysfunction. We got a bunch of them. So if that scapula is out of place, we can almost start to we can assume that that nerve problems are going to follow. Now it's not ideal, but most of us are going to have one scapular posture problem, not necessarily problem, but it's going to give us hell at least once in our life. So so it's important to know that the nerves communicating down the arm can help to alleviate especially shoulder and neck tension. This is when it gets too bad. So rotator cuff, thoracic outlet, subscapular injuries. We'll go through a few of them. Thoracic outlet can have a venous, a arterial, or a nerve component. And most likely it's going to be a nerve component, because if it's venous and arterial, you need surgery immediately. But the nerve right here at the brachial plexus, which is all those nerves running down the arm, the nerve will get impeded under the clavicle, and actually rather under the coracoid process when you raise your arm. So you don't see, I saw a client who had a displaced sternoclavicular joint, and so that collarbone would float in and down, and it would impede the nerve. And so a big part of our work together was stretching the nerve down the arm so that it could send big, long latency reflexes up all the way through the brachial plexus. Okay, you got upper trap compensation. You guys will see this a lot. I don't have to go into these paragraphs too much, but from a supraspinatus or a rotator cuff injury, you're going to see the trap start to raise and protect. Let's see, I got a chat. Was this a subluxation? It was a subluxation. Not one that I performed, but his collarbone was just like out, and it was out chronically, and it was affecting his nerve function. Okay, so abduction of the shoulder. So as if you're doing a jumping jack, once the arm reaches shoulder height, the deltoid takes over and continues abduction by raising the outstretched arm all the way to get overhead. But in an injured person, it's going to look like this rather than, so like a, also the other thing that the trap compensates for is scapular weakness. So the nerves of the scapula, if they aren't getting proper communication, the trap will take over. Okay, everyone got that? We have pronator syndrome. So I'm on my phone too much syndrome, or I'm riding a motorcycle syndrome. Compression of the median nerve in the region of the elbow or proximal part of the forearm can cause pain or numbness in the distribution of the distal median nerve. The most common cause of entrapment of the median nerve is between the two heads of the pronator muscle. So when we work in the elbow, we'll be addressing this pretty heavily. Cubitus valgus. How many of you guys have seen someone walking around that may have had an injury, but they walk around with one arm like this and the other arm is perfectly stable, normal, looks normal? That's called cubitus valgus, and it can affect the ulnar nerve. And so that can be hereditary, or it could be or if it's excessive, it's usually in some sort of injury sense. So, so you have both. If it's hereditary, there's not much you can do about it. It's just the positioning of the arm bones. But if it's from musculoskeletal injury, it can be facilitated and helped back into like a normal, not a normal range, but like a more healthy range. Okay, guys, so we're gonna go into my protocol. Goals for treatment. We're gonna try to spark off these long latency reflexes up the arm and shoulder. This is done by adding slow stretch to multiple tendon structures. And by slow stretch, I mean with our hands. So slowly, we're gonna get into points and we're gonna hold them for a few moments. And we're gonna see if we can get the breath to catch up to these long latency reflexes, and I'll show you what I mean. We're gonna be decompressing, so lifting up and away. And whenever I use the term fulcrum, I'm employing a leverage from my hands. So fingers on and the table, from my hands and fingers and the table to lift up on a joint. Okay, traction, we're gonna be utilizing traction and compression of the glenohumeral joint. And we're gonna do nerve glides. I'm gonna show you nerve glides and convergence in action. So we're gonna quote unquote break the palm at 90 degrees to the arm. And we're gonna watch these reflexes start to go off. We're also gonna employ something called resting retraction, and I'll show you guys. It's just 2 bolsters under the shoulders. Bolsters are so important. I don't like this move right here. This move, not a lot of people are gonna be able to achieve and be comfortable in, especially if they have glenohumeral joint problems. So we're gonna facilitate that in a different way. The move itself is valuable, but we need to not compromise. And this is a passive repositioning of the girdle in space, ensures that all breaths are going to encourage further passive facilitation of the Golgi tendon reflex. Quote, this encourages all the good work we just did. So I'll show you what that means. And then contraindications for treatment, guys, just there's one big one, and that's rotator cuff injuries. So you are not gonna wanna take someone with a rotator cuff injury up above 90 degrees. Just don't do it. You can work with their reflexes at 90 degrees. You can see them start to, like, even some of them are gonna have a tough time getting to 90. But don't go up over the head. And in a few of the moves, we're gonna be up over the head. So I'll show you where you just take it to 90 degrees. Okay, we must work within a range of motion and communicate clearly our boundaries. Cool, sounds good? Are we good? Awesome. Let me see how I do this. Okay, so I'm allowing you guys to unmute yourselves, I think. All right, yeah, cool. Any questions before I go get started? I'm gonna get Lucas over here on the table. Any immediate questions that are popping up? No? Awesome. Okay, let's go get started, guys. I'm gonna hop face down on the table and then just shirt off. All right, I gotta find my. All right, can you guys see the table here? And is it visible? Go ahead and unmute if you can.
Your device pointing at the tables is just black. There's no, oh, it's gone on there. There you go, it's on.
Perfect.
Sorry, we can't hear you, Eddie.
Okay, how about now?
Perfect.
Oh, perfect. Okay, there we go. Sorry about the difficulty there, guys. So again, this is Lucas. He's my buddy. He's a movement professional and a open format DJ. He's going to be our demo today. Okay, so I start by rocking his shoulders open. So what we want to do is we want to take disarming breaths and do tendon stretches away from the midline. Cool. Okay, deep breath here. I'm gonna mute all. Sorry guys, can you put your things on mute? Okay.
Eddie, you're on mute too.
All right, I think I got it now, guys. Sorry. Okay, so we're just framing the shoulder. We're taking disarming breaths into the shoulder girdle.
Video's gone, Eddie. You've muted yourself again and your video dropped out. It's come back, but you're muted.
Okay, so I think I'm here. I think I'm finally here.
Yeah, gotcha.
Okay, and if everyone could mute their screens if not already. Okay, so large disarming breaths into the shoulder. We're just framing the shoulder girdle here, and this is just how we start our protocol. Good. Now we want to facilitate just a degree of protraction, and we do that by framing the elbow. We don't push down, but we're going to gently push out and away and into the table just a little bit. So what we're doing is we're taking all the tendons in the elbow and we're facilitating inward rotation of the arm so that we see this protraction, this natural protraction happen at the shoulder. Deep breath. Good again. Good. And even with this, guys, you're going to notice that some reflexes will pop off, especially if the shoulder girdle has been kind of constrained to the thoracic cage or the rib cage. You'll start to see that this is a pretty big movement for somebody. Good. Okay, just like last time, we want to start open packing the arm. And this allows the trap to be lax and able to be manipulated. So we want to grab a medium, like a coconut oil, and we'll put that on the trap. And then we're on the left side. So using my right hand, we're going to brace just under the rib cage. And we'll use the left hand to come in and start to work that trap back medial to lateral. Good, deep breath. And then lateral to medial. We'll get up into the splenic muscles of the neck. Yeah, because you can, once you land on them and hold, you can start to feel these reflexes pop off. Now, the one reason I have my hand down here on the rib cage is because I really want to, one, feel the breath happening, and two, give a second. This can be quite an intense pressure on the trap. So I kind of want to give a displaced pressure to a different part of the body. It's almost like a trick. You can even come in with your other hand and start to work trap as well. Okay, our next move is a move that you're gonna see a lot of reflexes start to pop off, and we're gonna hold this. We're gonna hold this position so that we can allow that to happen. And what I did last time is I put my thumb up under toward the coracoid process, up under the rib, up under the pec. I take my other thumb and I put it along the scapular line. I have him take a deep breath. And exhale. Good, and go up. Cool, so you can see him start to take many deep breaths, as this is a completely new, it's a passive position, right? But it's a completely new position for him to experience, because the arm is under load all the time. And so we can start to elevate, and we'll get a deeper sensation this way. Good. We can retract, go higher. We can protract and start to pull out. And we can depress and push back. So, but all the while, this shoulder girdle is up, and we're finding that zero balance point, that 0 point of zero mechanical influence on the shoulder girdle. And we want to move that around, and we really want to feel into that so that we're able to experience, we're able to stretch all those tendons that feed into the shoulder all at once. Like, it's a big move. And we're stretching those Golgi tendon apparatus, which is telling the muscle in an inhibitory fashion to start letting go and start, it's going to tell tight muscles to let go. It's going to tell weaker muscles to engage and get more tone.
Eddie, are you able to show us on the pec where your thumb is resting? Because you're sliding in so easy here, but I can't see.
Yeah, it's going to be under an insertion. So, and then the other one is going to be framing the scapula, and you're just going to go up. So on the biceps tendon, or the pec, just inside from the biceps tendon on the pec.
Okay, that's good.
And then the other thumb is going to go on the scapular wing, and you're going to lift. Cool. Okay, then we actually go with our thumb. We actually go in, and we're gonna land on pec. Okay, guys, so you got me here again. All right, sorry, guys. So what I really want to stress now is now we can work on the pec from the inside, right? So a little bit of a stress point. We want communication to be proper, especially for our lady clients, but we want to work on the pec muscle and its insertion itself. So we'll take a squeezing motion with our fingers, and we'll land on that actual pec insertion. Cool. And then we'll have him take deep breaths. This is his body weight and gravity doing all the work. I'm barely using 2 grams of pressure on the tendon, but it's starting to open up, especially people with short pecs. It's very helpful. All right, and the next move is very important. So we're gonna take our opposite to his arm. We're gonna take our right arms. We're gonna take our right hand and we're gonna frame it under the glenohumeral joint. So thumb on the scapular wing, and then the hand is just gonna cradle the joint so that your fingers are almost on the outside here. Cool. Okay, then we're gonna grab his. I'm gonna grab his wrist very gently. I'm going to lift up. And I'm gonna pull back and away while I have this glenohumeral joint in a neutral position. So we found the 0 point of the glenohumeral joint right here. And now I'm going to add traction by gently pulling his wrist down and away toward me. Okay, now I have him take a deep breath. Good, we do it again. Good. And then we actually add compression and we go the opposite direction. Cool. By holding this traction in place and even playing a little bit with the tension that we put on the wrist, we start to see another number of those reflexes start to pop off. And it's kind of tough to see here in the camera, but I'm getting a little bit of delt. I'm getting a little bit of trap. I'm getting a little bit of shoulder stabilizer. And sometimes we get clonus, which is actual muscle contraction, all the way up into the shoulder. Good. Now remaining with that 0 point, we're going to come out and do traction like this, like a wing. I'll move the camera here, guys. Good. Now my hand is the fulcrum, right? It's holding and lifting that glenohumeral joint up. Deep breath. I'm just getting a whole lot of popping off right here, which is great. So this isn't a fast movement, guys. This is a very long, slow, boring movement. You just got to sit here and watch. But you got to add the appropriate amount of tension on the muscle or the traction. And you just got to sit and wait and watch. And you do this for as long as you need to before you feel adequate that it's starting to give a little bit of relief. Cool. And then you can actually push on the elbow and get a little bit of counter right here. So same position with the right hand, but we're just countering. And this is one thing you don't want to do with rotator cuff is you want to switch hands, cradle the glenohumeral joint, and then you want to lift this way overhead. Get a deep breath. And we're just holding this, guys. We're holding it with a little bit of traction. Good. We can switch, externally rotate his arm, and we can come back up. So it's an entirely different position. Cool. And so now, guys, if we've succeeded we've opened up this entire shoulder girdle. We've watched the reflexes go from our positioning of the limb all the way up into the spinal reflexes. It's really, really useful, really helpful. And so we're actually doing a lot of stretching, but we're facilitating that with our hands. It's not static stretching. He's not consciously stretching, which is so important. We're facilitating a unconscious or subconscious stretch. Now, the last thing I want to do while he's face down is just to bolster his shoulder up. And then we work soft tissue in the shoulder. And so we do that by bolstering with a simple towel, but you want to get it really thick. You can use shoulder bolsters. I have those, but not here. So you're going to place it right there under the glenohumeral joint. And you're going to see that, deep breath. You're going to see how it passively protracts this shoulder. And we can even start to push down on that elbow a little bit more. Not very hard. But this is like a multiple tendon stretch. Cool. We go to the opposite side of the table, and that's where we get our deep soft tissue work going along the rhomboids, along the levator right here. Along the splenius cervicus. Cool. We can even take that whole shoulder girdle and lift up and away, and then back down. Okay, so it looks like this. Okay, deep breath. And exhale. Okay, we can do it from the other side. So grasping with the 4 fingers, right hand under the scapula, left is going to be under the nearly the collarbone area, but also the glenohumeral joint. We're going to have him take a deep breath. And exhale and lift. Good. So that's an exaggerated lift. And the last thing I want to do, we can even introduce a sharp tool on the like on the medial elbow while we brace here at the trap. So left thumb on the trap, right on the elbow, deep breath. And this one, you can start to go just a little bit harder. And you can see that that's a really big release. So. Okay, guys, questions before we go flip him over and do the other side of his shoulder. So step 1, disarming breath stretch. 2, with the pressing of the elbow, medial arm rotation and passive retraction. Step 3 was continuing down the elbow and a few swipes on the trap with mobilization. Then we open pack the shoulder by lifting it up. We opened pack the shoulder, did the soft tissue, then we found the 0 point by lifting the shoulder blade up. and moving it around on our own.
Sorry, the screen's black for me when you were talking that whole time.
I can't hear you.
Where you're at on the video, you're muted.
All right, I don't get this thing. I'm so sorry, guys. So this should be it. So we did the shoulder girdle 0 point, and then we moved into the shoulder glenohumeral stable point, or the 0 point, and we did the traction, traction, and traction. Okay. And then we brought it back. We put it under a bolster, and then we protracted, and then we did soft tissue up and down the shoulder. Okay, if we did this right, guys, we're holding for a long time, and we're watching these reflexes have to communicate all the way up to the spine. You'll start to see clonus, which is muscle jerking, especially in people that haven't had this sensation before. And eventually, after a few treatments, that starts to go away. Like, they get accustomed and attuned to the space that is available in their shoulder. Cool. So I'm gonna have him flip over. Is there any questions before we move on to the other side? Yeah. Okay, awesome, Bethany, good. Okay, so scoot down just a little bit. Cool, always brace the knees so that the hips are open pack, and always keep the head neutral. So always put something under the head and neck. Good. Okay, guys, so when we're face up, when we're supine, I only really have four moves for you, four primary moves. The first one, we take his right arm, which is my right thumb, now that he's flipped over. We take my left thumb and brace it under his shoulder girdle. So my right thumb lands on the inside of his shoulder blade, and my left thumb is going to be cradling his shoulder. My left hand is going to be cradling his shoulder girdle. So I'll show you what I mean. We want to use a medium here for this because we'll be working with tendons. Okay, so with the right hand, I lift the shoulder up. I slide the left under. Okay, I cradle the shoulder girdle. And with my right thumb, I go into the axillary region while the rest of my fingers are up around his collarbone. And I'm gently going to press down with my thumb and move the shoulder girdle up. This is technically a 0 point. We're trying to find the zero mechanical influence of the shoulder girdle again. Good, deep breath here. And this can be intense, like an intense sensation. You're working with supraclavicular nerves. You're working with the pec and the brachial plexus. And you're just moving up. And you're moving that whole collarbone, which doesn't get much mobility at all. And you're putting pressure on your subscapularis, which is a tendon of the rotator cuff. Subscapularis, by the way, in something called frozen shoulder, it gets paralyzed. There's no function of subscap, and it's a good, this is a good modality for that. So these are very subtle movements that I'm making. I'm gonna exaggerate them up, out, down. Cool. Okay, what that did, guys, again, worked many tendon structures at the same time. We hit a stretch reflex or a Golgi reflex in many tendinous structures. So all of those had to feed back to the brain at the same time. We watched this enormous freeing of space, which is great. So that's what we want. Next, we move into a pin and maneuver of the elbow, and we do it medial to lateral, right? So you have the ulnar and the median nerve right here. And you have the radial nerve out here. Here we just find a neutral balance of the arm. We place the thumb on the median of the arm. I'm going to move the camera here. Okay, and we're going to press, and we're going to have him take a deep breath. We're going to press pretty significantly. Good, and then we can start to break the arm. We can start to pronate the arm and supinate. And if we're watching closely enough, we're watching that these nerve signals are actually going up into that brachial plexus. Deep. Okay, deep. Good, then we do it on the radius with the opposite hand. So left hand on the radius, same thing, deep. Oh, we got to jump there. Deep. Good, that was awesome. All right, then we're gonna move into move 3, which is nerve glides. And what I do is I feed my fingers, my ring and my pinky into his ring and his pinky. And I feed my ring, pinky, middle, and index around the other fingers. So it looks like this. All right. I'm gonna take his arm out. So I'm gonna lift up, I'm gonna find a 0 point. I'm gonna wait until he relaxes. I'll lift up, 0 point the shoulder. And then I'm gonna come out. And when I come out, you're gonna start to see these signals go up. Deep breath. And then what I'm gonna do is when I find that relaxation moment, I'm gonna start to break the wrist to 90 degrees. Deep breath. Major, major, major nerve signals going up. And we're holding it. We're not, I'm making it maybe minute movements, but we're basically holding this move. I'm letting him find space and relax into it. Good. After about 3 or 4 breaths, we can come back up again. We can move a little bit up, and we're going to take the same move into overhead. Now, this is one that we don't do with rotator cuff. Okay, deep breath. Okay, guys, and we're just holding it. His head's in a neutral position, so this is a really important facilitated move. Okay, and the last move I'm going to show you guys is pin and maneuver of the shoulder girdle. We're going to go superior to inferior. So I'm going to take my left hand, this is his right side. I'm going to slide it under his shoulder blade with my thumb on his trap. Okay, so you guys can see. Good. And what I'm going to do is I'm going to hold his wrist and I'm going to come out. I'm going to put my forearm on the table. I'm going to hold his wrist and come up, deep breath, while giving simultaneous pressure down on the trap. My palm is on the coracoid process, the AC joint. Good, deep breath. We're going to come up. We're going to come out, deep breath. And I'm not shoving down on his arm. It's very important. I'm facilitating his range of motion. I'm going to go into his range of motion and I'm giving a little bit more pressure and that's it. Deep. Good. Then you go a little bit more inferior. Deep. Good. And last one, you go all the way inferior. Deep. And then you cross the hand on the stomach. And that's it. So we did prone and supine. What we did was we facilitated major nerve movement all the way up into the cervical region. So like C5, C6, C7 is where those nerves go. And I'm gonna say thank you, buddy. Thank you. Thank you. And then I'm gonna communicate with them for a little bit longer. All right, cool. Okay, family, hold on one second. Okay, guys, thank you so much for putting up with the technical difficulties, and I will make sure to get all those angles right for the next meeting. So, not following when you say your palm is on the AC joint. From my view, I was cradling the scapula from the back, and I was not necessarily on the AC joint, but the very top of the shoulder. Right up here at the very top, I did have a little bit pressure pointing down. It's for Lisa, by the way. And so I was cradling the scapula from the back, but my palm right on the corner was wrapping around, and I was offering a little bit of pressure as I was pulling back. It's almost like a ratchet. I'm so sorry about the freezing, guys. I think it's my phone, but yeah, we figured it out eventually. So we receive a copy of my protocol for techniques. I'll tell you what, at the end of this whole thing, yes. But I think right now I can send you guys my slides, and I can send you guys my, what I'll send you guys is the video and the slides, and then I will copy down the techniques. But one thing they're all in my head, so I will have to put them on paper for you. Awesome. Okay, so the big thing here is we are introducing down the limb, we're introducing long latency reflex arcs. And they take, like I said, it takes a minute of stretch, like nearly 45 seconds to a minute to be in each position to start to feel these changes go on, and we feel it by introducing zero. So at certain joints, we're influencing like zero mechanical influence or zero. It's like a no physics like point in the shoulder girdle and one in the shoulder joint. I'm a little bit sweaty. It's a little bit hot here. So, but the but when we influence that ability to relax, when we influence that ability to completely relax, those nerve signals can communicate and flow much greater and with much more like what's called wave summation. Like it gets a much bigger response as we start to open up the cradle. Yeah, Bethany, I'm gonna unmute you.
Okay.
Okay, cool. Hi.
Hey. So that was cool to work along with you for that. I just had a question when you were talking about observing the response happening. So I imagine obviously like with more time, my touch will become more familiar with what that feels like, the releasing or the letting go, the latency reflex you're looking for. When
Right.
you're visually watching your client, when you were kind of talking like you could observe the nerve reflex go up and back. So
Sure.
I was just curious if that is part intuition or like you're physically observing something.
I am physically observing their breath reaction. I'm also physically observing possible clonus, which is I'll define it on the next class, but a clonus is an action potential. So a clonus is a unconscious muscle contraction. And you guys have experienced these. I know you've experienced these. I know you've seen these happen.
Yeah.
But if we facilitate opening up, you see a lot of those clonical reactions go off, and that's certainly an observable thing and a tangible thing that I want to see. But a lot of it is intuition of the hands. You're going to know when you're going to know when that joint capsule is opening up. You're going to know when that shoulder girdle is opening up. You're going to know when to go a little bit. These are very subtle movements, and it's really hard to get on camera. But you're going to notice like when you can go just maybe a centimeter or less more, and you'll see that it'll elicit these major changes. So
And what are you looking for with the breath? What are you observing there?
Either they're gonna want to take a deep breath because it's a novel position that they haven't been in before, and they need to like cope. Or I'm gonna coach them when I see that they can take a deep breath, when I have the adequate positioning, and I say take a deep breath, and we're gonna go. And this has a lot to do with the shiatsu question from last week. We can go deeper on an exhale, so we can coach the breath and go into a different position, and then that opens up a whole new door, and then they'll take another deep breath, and it's a really like a back and a forth. And so breath is really a pattern. Breath work is really the work to, I guess, find a new pattern, but like your breathing's naturally going to be in a rhythm and a pattern, and we want to work with that. And that has a lot of help in other ways, especially when it comes to autonomic function and the breath and being safe and all these other things.
Hey, I had a question.
Yeah, Trudy.
Does it matter if you're prone or supine first? Is there like a specific order that it should be in?
Yeah, it's in the slides, and I'll send them over to you. But I definitely want to start prone first. Prone for at least 60 minutes. It not only is important for down regulating the entire human body, because your head is in a neutral position. It's a position that we don't get into at all every day, and it's very useful, unless you sleep on your table, which I have done. But it's really important to start prone, and you'll see that not everyone can start prone. Some people will actually request like, hey, I'm not real safe not having my eyes to the horizon, and then that's okay. You just start supine, but 60 minutes prones, 20 minutes face up is ideal.
Okay, cool. Thank you.
Cool. All right, how are we doing, guys? Can I facilitate any more questions? I also would like to say, just before I do that, starting next week, if you guys have a question that pops up during the week, send it to my email. We'll answer it first thing on the next class. Awesome. All right, well, I'll give us a count of 10, and then I'll end the video, and I want to thank you guys very, very much for joining me. Cool. Last chance for questions. Okay, we got a question. All right, thank you, Michael. Good to see you. Cool, thank you all. Thank you, guys. All right, bye. Have a great, great week. Take care.